Hello, and a warm welcome. This is CytoSorbents calling, so to say. My name is Stefan Baudis. I'm VP Global Affairs at CytoSorbents, and I want to welcome you all here to our webinar. I could already read that we had registered participants more than 100 from 32 countries today, and including people from Latin America, for example. So good morning to you, and also people from Far East, from Singapore. So good afternoon or good evening to you. And it's a big pleasure to welcome my dear colleague here, Dr. Maria Soledad Taborda Küpper. She will talk today about an update on CytoSorb therapy in liver dysfunction. And before we start that, I'd like to tell you that we have today a translator on board. So if you want to listen to the presentation in German, you can do that. Just use the button below on your screen. And in addition, of course, we like very much that you send us questions. So there's an F&A button, and we hope to discuss with you later on a little bit more about the details of the use of CytoSorb in liver dysfunction. Yeah, and I have to say that this indication is a very hot topic since several years. But nowadays we get more and more data, more and more publication. We will also talk about that. And that illustrates very well the importance of this indication. And some personal words. I'm very much involved in this topic since many years, as I was introducing another liver support system more than 20 years ago. And now we have CytoSorb on board, and I can say this is really a gift because it has so many advantages to many other liver support devices. And we will talk about that, of course, later as well. Yeah, so that's my introduction here. And now I'd like to hand over to Maria. And again, a very warm welcome to you.
Thank you very much, Stefan, for the kind introduction. Good afternoon, good evening, and good morning, everyone. Pleasure to have you in this session and to find out a bit more about CytoSorb and what can we do for patients with liver dysfunction. Our presentation will be composed on three main blocks: a bit of generalities of the adsorber, what is the problem and how to address it, the liver dysfunction, and a brief overview on literature and clinical data. First of all, CytoSorb, so the vast majority of you know it, and for those who not, let me introduce you to the device. It's a whole blood adsorber. It's composed of beads of polymer, porous beads of polymer that have the capacity to remove excessive level of substances from blood. Substances within a size range between 10 and 60 kilodaltons, and these substances must be, per definition, hydrophobic. And need to remind you all that the adsorption is a process that is not mediated by neither filtration, dialysis, convection, no washout, and also no ligand processes involved. This means occurs autonomously and can be combined with any of these technologies if needed. I also would like to highlight three main characteristics of the device. The first is the size selectivity adsorption. Substances smaller or bigger than this adsorption range cannot be retained. The second is that this absorption or this removal will always be concentration dependent, meaning that no substance will be removed to 100% of elimination rate. Very important, because rarely we want to eliminate 100% of something, especially if it's a natural substance, and very biocompatible materials. This does not induce coagulation events, activation of the complement, or immune responses. And I need to emphasize this because safety matters. No introduction or no intervention in medicine is good enough. It creates problems. And within this size range from 10 to 60 kilodaltons, there are plenty of substances that might be of interest for us in the daily practice. Currently, as of 2022, authorized use of CytoSorb mentions these substances. Some of the majority of you maybe have heard of it in the context of cytokine removal, for inflammatory cytokines mostly, or in cardiac surgery, the elimination intraoperatively or ticagrelor or rivaroxaban might be of interest. Yesterday, we had the chance to discuss in the webinar how the removal of myoglobin can be useful, but also the subject of this webinar today is what can we do removing bilirubin and not only bilirubin. And in our document considerations of use, you will find more information that will enable to see which substances might be therapeutic goals for the hemoadsorption therapy. With that, let's go see what happens with the liver. The first of all is that liver, or better said, liver dysfunction, does not sound or does not speak to us in the same levels in acute or critical care medicine. To begin with, because classically, we like to put labels to conditions of the patients. We need this. When classically, when we think on liver dysfunction or liver disease, we think on primary liver disease. That can be acute. A previously healthy liver suffers an injury and occurs an event that leads to dysfunction of this organ, or the liver is chronically ill, regardless of the cause, and there is a chronic liver failure that might exacerbate, and this might lead to acute deterioration of the patient. But liver dysfunction, especially in acute care settings, has many other flavors that we tend to not see so commonly or to keep on front. This might be affecting the liver function of our patients. Example given, post-hepatectomy liver failure. A healthy liver or a functioning liver undergoes an injury that is basically the resection. Traumatic, oncologic, regardless of what was the reason for the resection, the remnant of the liver needs to catch up with a function that was drastically and suddenly reduced. And this might lead to a liver failure that we cannot categorize as acute or acute on chronic. Also, and very common in the context of patients that we treat in the intensive care unit, drug-induced. We remember from our pharmacological classes in the university, the profound impact that many substances and drugs have in the metabolic pathways in the liver and how the liver can respond negatively to them. And this, in the context of polymedicated patients, plays a role. And sometimes we have more clear that the cause of the liver injury was drug dependent, but in some others not. Adds to the condition of the patient. Also, sepsis and the components of the sepsis, direct infection, hypoxia, or hypoperfusion, the concept of shock liver. All of these, we could roughly summarize it as sepsis-associated liver dysfunction, and it's also a liver failure or a critical liver condition that we cannot easily categorize in acute or chronic. And after we have treated our patient and our patient leaves or improves from the acute phase, we have another problem, in a serious one, and that is becoming a bit more obvious every year. The liver and the bile ducts are quite sensitive to what happens with the patient in the acute phase, to the damage that is caused by hypoperfusion. And now the concept of secondary sclerosing cholangitis in critically ill patients is starting to become more present in literature. It's starting to become more present in daily practice. We rescue our patients, but we know in the acute care very little of what the consequences are on the long term. And not only in the long term, in the midterm. Regardless of the cause, the composite of symptoms or signs of liver dysfunction is very, very broad. We characterize this typically as rise of liver enzymes, a rise on the toxin levels, impairment of other functions, coagulation classically, or synthetic functions of the liver. It is beyond the scope of this webinar to discuss in detail the definitions of acute or acute on chronic liver failure. Just want to give you a flavor on there is more than what we like to categorize as liver disease. But regardless of the cause, what we do know from a pathophysiological standpoint is that we have an initial event of any kind, and that this initial event leads to something that we can detect, usually symptoms or rise of liver toxins. That might be bilirubin, bile acids, or ammonia. And secondarily, though might be only hours between one and the other, organ dysfunction signs begin to occur. And of course, we like to address them as failures: brain failure, kidney failure, cardiovascular failure. And what is the problem with that? That the liver dysfunction can lead to multiple organ failure and seems to be, so far, the composite of an autointoxication, this rise on the liver toxins or the substances that are not being properly cleared, plus the immune dysfunction, because and we know more of that every day. The liver plays a major role in an immune system. So anything damaging the liver will also reflect in our immune response. And if the patient is infected, and this is whether it's an open or an overt infection or a not so overt infection, there is more to the story than just the immune damage of the liver. And this might express as synthetic impairment function, coagulopathy, kidney failure, encephalopathy, cardiac failure also. And the patient can progress not only to an hepatorenal syndrome or a hepatopulmonary syndrome, can develop ARDS. And it's the composite of the organ failure what determines death or poor outcome. Now, as mentioned some seconds ago, the detoxification aspect. Where is the damage of the toxins? Classically, we'd like to address that liver failure is visible because we see the patient with icterus. We see the jaundice. The patient, the mucosa and the skin develop a change of color that we tend to classify as above 1.5 milligrams per deciliter. But are the levels of bilirubin dangerous? Not so clear, or at least not in the past. We did knew, thanks to the neonatologists, that when the patient is a neonate and has a very permeable blood barrier in the brain, then kernicterus occurs, accumulation in the nucleus, and that this is not good for a pediatric patient. But in adults, we do not suffer from this. This was not our problem. Our problem now becomes in the other direction. Is bilirubin, or chronically increased levels of bilirubin, damaging organs? And more evidence points towards that direction. It has been associated not only with a prediction of a poor response to vasopressor therapies in patients with hepatorenal syndrome and kidney failure, but also has been becoming a mortality-independent predictive factor in septic patients and in patients that are under ECMO therapy, which means no longer is color, it's also damaging. And with the bile acids and combination bile acids in bilirubin, also is happening the same. The bile acids, classically, we associate them with pruritus, based, of course, a broad variety of bile acids, hydrophobic and hydrophilic or amphiphilic. But the problem is what happens with the chronic accumulation in bile acids, and these very, very compelling images of how the biopsy of kidneys of patients that have been suffering from liver dysfunction looks like. Concept of the nephropathy secondary to bile casts and the relation between the bile casts and the kidney failure leads us to the question, maybe removing these could protect the kidneys from damaging in these patients. It's food for thought, but it's quite compelling to see that we are dealing with more problems that I must confess I did not have to clear when I was studying medicine. But also the inflammatory response, the hyperinflammation, what happens with that? We like to refer to the liver is this mighty organ that also plays a role in the immune dysfunction, but does immune dysfunction play a role in the liver failure? Also, yes. And already we and collaborators have mentioned something on this and presented a very, very simple graphic, resuming pathways that clearly are pointing towards these cytokines, pro-inflammatory cytokines, TNF-alpha, interleukin-1, interleukin-6, signaling receptors and signals of cytokines are being hyper-expressed. And this is playing a role in the liver injury that is immune-mediated. It's no longer the tissue damage because it suffered an hypoxia, because it suffered an infection, because it suffered a trauma, but also an alteration in the immune response is further damaging the liver. And in acute and chronic liver failure, this very, very compelling work from Dr. Ferrells and collaborators also addressed that. There are patterns, and patterns that become more visible. the hyperinflammation in a patient with acute and chronic liver failure determines what is happening with this patient. And not only that, determines also the outcomes. In this graphic, you see the difference between the surrogates of systemic hyperinflammation over the course of time in stable cirrhosis, unstable decompensated cirrhosis, the pre-acute and chronic liver failure status, and the real acute and chronic liver failure status, clearly showing that the more inflammation we have, the more organs are failing. And this is something that needs to bring us to the question, are we seeing this disease in the holistic integrative approach, or are we seeing that as only a toxin problem? And on top of that, the real emergency, what I as intensivists have seen and what many of you have seen also in daily practice, not often, but when it happens, is catastrophic, hepatic encephalopathy. And we have learned to identify one of the bad guys, ammonia, a small, very small, dialysable. But turns out that patients not only match the ammonia levels with their clinical condition, and hepatic encephalopathy might be grade 1 or 2, despite high ammonia levels, and the other way around. So the group of Dr. Montagnesi has already presented a very interesting approach on what might be the combination of pathophysiological mechanisms behind that. And for many years, we put the blame mostly in ammonia, but it's becoming increasingly evident that also other substances, including pro-inflammatory interleukins, indoles, and mercaptans, are playing a role. And this has been also, and I encourage you all to read if you have not had the chance, this very, very interesting review in Nature from the group of Dr. Huizinga regarding how ammonia and pro-inflammation are hand in hand in what is happening with these patients. The cautionary tale for us is it's also a problem of cytokines. It's more than just ammonia levels. And this explains why clinically we do not see always the same patient with the same degree of hepatic encephalopathy based only on lab. Now, a very common question, can we replace or support, as Stefan would like to say, the liver functions? We all have it clear. In the moment that we use the word fulminant liver failure and diagnose, probably the best practice is to consider transplantation and to report and bring this patient to the list as soon as we can. And it's the right thing to do. The problem is there is a period of time variable, and there is great variability even within the European Union in how fast you make it from the list to the OR. And in the meantime, what do? The patient remains in a critical care unit under all possible measurements, and then brings the question, can we use extracorporeal liver support? Can we do something to replace functionality, or at least to provide some aid? And very well summarized by the group of Dr. Lee already in 2016, this is what I like to call a wish list. What do we expect of an extracorporeal liver support device? Ideally, the device should bridge either to recovery, assuming that the liver was previously healthy, or to baseline, assuming that there was a certain degree of liver disease that experienced an acute decompensation, but that we cannot or will not transplant the patient right away. But maybe the decision is still to transplant. And regardless of the cost, the patient should make it in the best possible condition to transplant. And this is then what we like to call bridge to transplant. But also, we would be really, really thankful in practice if the device can do something for the organ dysfunction. The hepatic encephalopathy improvement would be already a good hallmark. But if it can improve organ functions and detoxify, better. But on top of that, again, this is a wish list. We also expect of these devices, when possible, to reduce inflammation, but not only to reduce inflammation, to preserve the immune response that the patient needs. We want to avoid a paralysis. We want to ensure that the patient has defense mechanisms active to protect himself against infection or whatever it comes. And this brings us the question, where could we, or which of these aspects could we help with CytoSorb? And we will see. And I would like to bring this topic of discussion, because when I tell you that there is an option with CytoSorb, it's because literature, even though it's short in number yet and has to grow, already has pointed towards this direction. Now, many, including my practice too, would have good reasons also, and would point at common caveats with extracorporeal liver support devices. And varying amongst countries, healthcare systems, and practices, we will find that first, unselective removal is a problem and a fear. The inability of many of these existing systems, with exception for therapeutic plasma exchange, to tackle, to address the immune dysregulation is also a problem and has been seen already as the result of analysis. And a very, very interesting one is published by the group of Dr. Stadelbauer, that a common caveat with some existing extracorporeal liver support devices was they could not address this elevation of inflammatory levels of cytokines. And of course, procedure-related complications. If you have clots, thrombocytopenia that is severe, or bleeding events, or have problems with electrolytes, or have problems with reactions, this might, of course, be a good reason to try to consider whether I really need to apply this or not for the patient. On top of that, complexity, length of treatment, need for anticoagulation might also be a question that we don't know what to do, and especially in this case, in these patients that tend to have coagulation impairment, but also the need of albumin or plasma. Plasma is a broad product, an expensive one, and one that we do not have available as often as we wish. And albumin is a biologic product that also is costly. Of course, another very, very good caveat is, what about the evidence? What if the therapy does not modify the outcome? And we have seen this. RCTs have failed in the past also with devices, but needless to say, when the goal was mortality, and depends a lot of the type of patient, depends a lot also on, are we looking at the right patient and are we looking at the right outcome? But certainly this adds to why we are not using in routine practice extracorporeal liver support devices. At the end, we have to be able to demonstrate. And last but not least, cost. Costly devices and costly disposables play a role. Sometimes we do not do it because we cannot afford it, and because we cannot transfer the cost to the patient. So there are lots of problems that we, in development and research, as clinicians and also in the industry, have to be able to respond, have to be able to come with a solution. At the end, it's all about benefit for the cost. And this brings us to, why would I suggest or consider to treatment the hemoabsorption with CytoSorb in a patient with liver dysfunction? First, because you have the possibility to bind selectively hydrophobic toxins in blood that include bilirubin and include bile acids. Second, because you have the possibility to remove excessive levels of inflammatory mediators. You have the possibility to target an aspect of the disease that had not been targeted so effectively by the vast majority, not all, of the therapies available before. But additionally, because it's independent from the treatment or the necessity of plasma or albumin, combinable if needed, and there is already experience on that, but not necessary to remove bilirubin and not necessary to remove cytokines. There is room for synergistic approach. And also there is room for synergistic approach with other organ support therapies. You can treat liver dysfunction in a patient that is receiving ECMO. You can treat liver dysfunction in a patient that does not have yet acute kidney injury. There is a possibility of applying hemoabsorption and giving the patient the support that might need to detoxify and to improve the immune response. And as my boss likes to say, a picture says more than 1,000 words, and cautionary tale. This is not how all adsorbers will look like after the treatment. This was a very concrete case. You can remove and visually see the effect. Needless to say, not all patients would look like that. But common question, is bilirubin removed conjugated or unconjugated? Both. So probably the color will change in response of which bilirubin are you extracting. See it as a tool for extracorporeal support. Other known systems, and a common example, the complexity of the setup of other available technologies and the need of albumin, or more simple, a proof of concept, a proof of technology, a concept, plus therapeutic plasma exchange. To really do effective therapeutic plasma exchange, to really modify the outcome in a patient with acute liver failure. And I can only refer you to this fabulous RCT from the group of Larsen. you need to apply the treatment with at least 15% of blood volume, which namely is from 8 to 12 liters of replacement. And this has to be done at least 3 days in a row. It's not that it's bad, but definitely implies the use of resources and definitely implies an intensive attention from the staff. There is still, of course, plenty of room to do plasmapheresis, and I don't see this necessarily as a replacement. I'm just saying, mind that this has requirements, it has expenses, and it has intensity of workload. And with CytoSorb, you can really be easy and flexible. You do not need to use albumin, but you can, if the patient has an indication for albumin dialysis or for albumin replacement, can be performed simultaneously with CytoSorb, and there is already experience on this. Can be integrated when the patient does not present yet kidney injury, if other criteria is met. Can support when the patient that is receiving ECMO treatment has already high bilirubin levels. In this patient does not have a criteria for replacement therapy, but you can help to reduce this bilirubin and try to do your best to improve the outcome of this patient. At the end, it's about targeting the critical aspects of liver dysfunction. Reduction of inflammatory mediators should help to improve microcirculation that may be in shock or not, and sometimes it's not so overt that we have a problem in the microcirculation. But the majority of these patients have, especially if we don't chronic, and this is why we use vasopressor therapies. The reduction of protein-bound toxins should also help us to reduce cellular damage. And we have seen not only that, to reduce damage for deposition, but can help us also to improve immune dysfunction and reducing not only neurotoxin load, but improving hepatic encephalopathy. You can reduce the brain damage. Once the astrocyte edema is established, we have gone as far as to, and there is already reports on literature, to perform craniectomies, because there is no other way to go out of this situation. And the question is, can we treat a patient with hepatic encephalopathy before going to such a radical solution? It's worth it to try. Basically, this is about attenuating this downward spiral. Systemic hyperinflammation will lead to organ failure, and organ failure will further worsen systemic hyperinflammation. And with CytoSorb, the idea is precisely to have the opportunity to reduce cytokines and reduce toxin circulating and give a patient a way out of this decompensation. And even of that, it's too early to tell how the impact of that will look like in 6 and 12 months. But in an acute case where you know that that is impending, it might be worth it to do it, but on time, before it's too late. And with that, and maybe some of you have seen this or not, and if not, I would like to take the chance to introduce it. We have released some weeks ago a decision support card that should enable us to find answers to common questions. And a common question is, which patient would benefit from receiving the treatment? And based on that, and compilation of current literature and best practice, with the goal of removing liver toxins and with the goal of attaining immunomodulation, we have listed, and it's only a list. It is not all of them have to be available at the same time or have to be present at the same time, but consider that a patient that has a high bilirubin levels above 10 milligrams per deciliter or 170 micromoles might be beneficial already to remove this, because it's already too high, and the association with poorer outcomes is worse. A patient that has an hepatic encephalopathy that has not responded to conventional treatment with lactulose and rifaximin, how many options do we have after? A patient with an acute liver failure that's really decompensated with multi-organ failure, what are our options left? We have to try to provide them an option that might help them and recover them from transplant, or might make them be able to wait until an organ becomes available. The same happens with criteria that we know already from other applications of absorption that might be also present in these patients. If a patient is in septic or vasoplegic shock, unresponsive to conventional treatment, and on top of that, back to the question, if the patient has concomitant vasoplegic shock, is a patient that might benefit from the application of the therapy. It's worth it to integrate this in our practice. But also, what if the patient presents a liver failure after surgery? That we know that the problem needs time before this remnant liver function overtakes. We might be able to give them an option. And So there is experience on that, and so we would not see this as a medical emergency in intensive care. Intractable pruritus might be also a condition where failure to standard therapy might be able to provide a solution for these patients with hemoabsorption. So as said, consider that there are flexible criteria that you can integrate in your practice when all available options are not doing what you expect of them. And that on top of that, you can integrate this in any type of circuit, extracorporeal circuit that you have. The patient does not need to be in good criteria of starting renal replacement therapy immediately to decide the application of CytoSorb. And before going to a brief QA session, would like to say that for continuation, again, best practice based on input from the field, from the users, and some of them are here today and would love to hear also, if possible, their input on this. What is the goal? Depends on why we started. If our goal was to treat high bilirubin values, is this decrease which should lead to when I stop the therapy or how often to exchange? Bilirubin is fortunately quite available to measure. If we do not see a sufficient drop, maybe the patient needs an earlier exchange. If we are satisfied with the delta of removal, then we might consider that the therapy is, as its current state, effective. And we can also take a look. If we are not meeting the results, maybe it's time to stop. But we have to be able to treat first and foremost the patient and the evolution of the patient and make decisions accordingly. And with that, I would like to make a pause and see if there is any question that we might be able to address in this meantime.
Yeah, Maria, thank you very much for this great overview. I have one question to you. You were talking about CytoSorb as an option to bridge patients to liver transplantations. So I think this is a very nice indication, of course. Do you have any ideas for how long one could do that? Are there any examples you remember?
Well, I can quote two examples where the therapy lasted longer. Maybe you have 2 or 3 more years than me and the company. You might remember another cases as well. But the longest case that received hemoabsorption, maybe not in the context of transplant, but at least documented, if I recall this correctly, was 52 days. And there have been patients that have received for more than 2 weeks bridged therapy in the context of liver failure with listing for transplantation before the organ became available. And here the important aspect is exactly that. Maybe without liver support, without the option of this, the patient would have not lived these 2 weeks, remains a topic of debate. But what we do know is that when an organ is not available and the condition of the patient does not improve, one of the most, if not the most common cause of withdrawing off the list is death. And the possibility of keeping the patient in a condition where is ready to be transplanted because its clinical situation allows the surgical stress is a valuable tool.
Yeah, I think it's of course different. Yeah, sometimes organs are available, sometimes not, and so on and so on. Yeah, I have one question from a guest here, from Mehmet Ucar. I think he's from Turkey. He's asking about how are antibiotics affected during hemoadsorption. I think this is a huge complex topic, of course, but maybe you can try to answer that in short. Maybe we have to do an extra webinar regarding this topic, but yes, maybe you can answer that in short.
Very, very good. That is an excellent question. Definitely, we have to consider to apply a webinar session to address that. So the first thing to say is absorption of medication, regardless of whether they are antibiotics or not. One can test it in vitro, one can see it in vivo. Those are already 2 clinical situations that are different. In vitro, of the most common antibiotics, there is already literature that has addressed the impact of hemoabsorption in the majority of the common use antibiotics in the intensive care unit. It's available, and I think that we can share the reference or the link to the literature database on the topic. The vast majority are not removed at all. The second, maybe 30%, might experience a minor removal.
Mhm.
And there are one or two cases concretely where there is some degree of removal that might be relevant or not, but one has to introduce caveats here. First, an in vitro trial or even an animal trial does not replicate one-to-one a human model. A human model or the patient varies greatly the bioavailability and the pharmacokinetics and pharmacodynamics, whether he's healthy or has a third space or presents liver or kidney injury, because this affects the metabolism of the drug. So from the practical perspective or recommendation, and I would like to emphasize that there is guidance on this in the document considerations of use, is for the substances where some degree of absorption might be documented, we strongly recommend to do therapeutic drug monitoring, but this is not a different strategy of what we do with other medication that we know that is sensible to extracorporeal treatment. And that leads us to the second part. There is also an impact in the drug clearance and in the antibiotic and other medication value, secondary to CRRT, intermittent dialysis, and even ECMO. So one cannot completely rule out the impact of absorption, but one should also not overlook the impact that other extracorporeal therapies that might be used simultaneously with CytoSorb have in the impact on the drugs. So like everything, who is to blame?
Yeah, I can make maybe two comments on that. We just came back from Paris from the ESICM Congress, and we had a wonderful symposium. And one lecture by Professor Mitzner was addressing exactly the topic. And if you like, you can follow this. We will send you the link here, so you can listen to his presentation. I think that was a wonderful overview and underlined very much what you said, Maria. And on the other side, we have a wonderful article by Shire et al. You can look in our literature data bank, and you find really good answers to this complex topic. Yeah.
Yes.
Yeah,
Well,
but I think we have to continue, Maria, because
of time.
it's limited time. We want to talk now about literature, about the data we have, and I think there's some new data available, and others are in the pipeline as far as I know. So, but if you can continue, that would be great.
Perfect. Thank you very much. Then, as Stefan promised, literature and clinical data. First disclaimer is, there is more to come. And let's take a look at that. From a mechanistic standpoint, the first thing that I would like to address is how this performance of CytoSorb can be compared with what we would see maybe as reference in the field of extracorporeal liver support. And of that, and with the authorship of Dr. Dominic and Dr. Stange, are ready a documentation on the similarities, the differences, and the potential synergies between CytoSorb and the molecular absorption recirculation system are available. Please mind, this was an in vitro evaluation and was able to show what we already knew. The Mars can indeed remove total bilirubin and bile acids and CytoSorb, and in light gray, you see the reduction data from CytoSorb. Looks like the removal of toxins is superior with the use of CytoSorb. But on top of this, they also measure how the behavior of common pro-inflammatory interleukins occurs after the treatment. And as expected, and this was, again, something that had been already reported by Dr. Stadelbauer and collaborators, the impact on interleukins was almost negligible with therapies like Mars or Prometheus, in contraposition with CytoSorb, where clearly the removal is to be seen. And their conclusion was that the patient, or that in this model, the reduction of cytokines or the removal of cytokines, as well as the removal of albumin-bound toxins, they include ammonia in their measurements, could be seen. And last year was also published, finally, the review of the so-called liver indication in the CytoSorb registry. The CytoSorb registry was an international registry of CytoSorb use, whose final results were published as of 3 days ago, where they took as one analysis of 109 patients of this massive registry, 1,434 patients treated with CytoSorb, and they analyzed the concept of when had they been treated due to a liver dysfunction indication. And please mind that the biggest and foremost result that they were aiming in this was the change or the delta of bilirubin removal from an admission to the moment of finalization of the treatment. And what they could find was statistically the removal of bilirubin was significant and already planted the seeds on how and when should we execute the studies that allows us to find the value of hemoabsorption in liver dysfunction. And this is at the end what matters here. Data to be obtained, data to keep obtaining. We have to find out more, and we work closely to find more. Another case series quite interesting from Italy, and I address this specifically because it is a composite of a patient with liver dysfunction in critically ill patients that were, on top of that, receiving ECMO support. This is from the San Rafael group in Milan, and they took a view on how values of bilirubin and on transaminase and lactate were looking before and after the treatment, and contrasted these with indications for starting the support. And as you see, there were patients whose indication was liver failure or hyperbilirubinemia. And in these patients, not only they were able to reduce, and mind, this is a citation, toxic molecules such as bilirubin, lactate, C-reactive protein, but I would not say that lactate is per se toxic, but important, they could also correlate this with a reduction in the vasoactive score index. They could reduce the vasopressor needs, and they could document a lower mortality than what was expected by scoring systems of severity at admission. So they were able to correlate the application, the bilirubin removal, and the outcome of the patient. And though it's a smaller group, it's good to know that this patient, the critically ill patient, regardless of the cause, where a hyperbilirubinemia or a liver dysfunction is already established, can benefit from the hemoabsorption. Another case series also by Dr. Tomescu, who was also present in the ESIM symposium and gave a fantastic lecture on the use of CytoSorb in liver support and in pancreatitis. Please go see, because she does it better than me. What I wanted to quote from her was exactly this. If you take a case series, 28 patients with infectious and non-infectious causes for acute liver failure. And in this subset of patients, there was also documentation, not only on that indeed it can remove bilirubin, but can improve ammoniac values, can improve C-reactive protein values. Can this represent a clinical impact on the SOFA, at least the SOFA for the liver failure? And this is the answer, looks like yes. Not only that, at 64% survival rate, Mento is a case series and would warrant to go and obtain prospective data. It's already promising. Shows an improvement in the liver functional tests, because one could argue, and now we have more info, that yeah, the detoxification aspect of the hemoabsorption is valuable, but we have to be able to correlate this with organ functioning tests. Another case series from Germany, also published last year, evaluated 33 patients also with acute liver dysfunction, not necessarily failure, whose bilirubin levels were above 10 milligrams per deciliter. And these patients were divided into cohorts, one treated with CytoSorb integrated in CRRT versus other extracorporeal liver support devices. And we're able to document that yes, both interventions can reduce indeed bilirubin, that was in both cases quite high before the treatment, but with the CytoSorb group, they were able to see as well a decrease on transaminases that is not to be attributable to the hemoabsorption because they are too big. They are way bigger than 60 kilodaltons. And that this, therefore, they interpret as a potential improvement in liver function. But not only that, the ease of use of CytoSorb is what gives them a leverage against other procedures. It's not that there is only one solution to liver support, but rarely, if not, we had not had in liver support a solution that was so practically flexible to implement, so easy to use as this one. There are plenty of other case reports in series, and just to give you a flavor, in septic-associated liver dysfunction, in patients with secondary sclerosing cholangitis, in patients that needed bridge to therapy, from small babies to adults, in patients that needed to get bilirubin removed during cardiac surgery. And all of this is available in the literature database. And with that, I would like to summarize 4 key messages that I would like to transfer to you before being open to your questions. And first one is that, yes, liver dysfunction is still complex. It's still a situation where we cannot fully grasp what is happening in all cases, but we have to do our best to detect it, and we have to do our best to treat the patient promptly. That the impairment in the toxin clearance plus the dysregulation of the immune response are associated with organ damage, and this is associated with poorer outcomes. The more toxins are there, the more inflammatory mediators are there, the damage to the organs and the point of no return of these organs is worse. That the absorption seems to provide not only a very, very clear, strong message, and we can remove toxins and we can modulate inflammatory response, but I want to emphasize it's easy and it's flexible and can help to improve biochemical parameters, but also clinical. If the liver or the organ scoring systems to measure the organ function are improving, this is a sign that the patient has a better possibility to recover. And as with all therapies, and I always like to emphasize this is no different from any intervention that we use in patient care, selection, timing, and dosing. And of course, we still have plenty to learn. Of course, we engage in generating data, but I want to only address, there is people here, maybe not all of them in the meeting, but these that are already using it, without them, we would not know, because there is a limit from what can be obtained from in vitro data. Is the data that comes from the users the one that lets us know if our hypotheses are going in the right way? With that, I would like to close. Thank you for your attention. Remind you the link of our literature database, and I'm completely open for your questions. Thank you very much.
Yeah, thank you very much, Maria. I was really impressed about the data you presented. What is the main reason why is CytoSorb so widely used? I mean, there's no big evidence. CytoSorb is not present in any guidelines yet. What do you think? What is the main reason for that? Is this ease of use? Is this the potential to remove not only bilirubin but also inflammatory markers and so on? So what do you think? What is yeah, the great interest in this therapy now?
Well, I think that after taking a look at what is available there and taking a look on how other extracorporeal liver support devices, including bioartificial liver developments, have behaved in terms of market presence or disappearance in the past, but it's a very good skepticism still between liver specialists and non-liver specialists to implement so firsthand concepts or technologies where things are still unclear from a mechanistical standpoint, or where availability or complexity pose extra challenges. We cannot neglect, especially in current times, that healthcare authorities, private or public stakeholders, will ask from us a justification, and a justification that is more necessary the more expensive a treatment is. And the skepticism plays, of course, a role with what was happened in the past with other interventions and their failure to meet outcomes. So retrospectively, analysis of this data suggests that selected patient groups can indeed benefit, and that specific emergency situations can benefit. And I think that one has to work not only towards having an option, but being able to find the patient that benefits the most. And then, not to overlook, make these technologies easy and accessible. And without ease of use and accessibility, you can have the best possible tool in hand, but will not service the greater majority of patients.
Okay. So ease of use is one big argument from your point of view, and the flexibility of the therapy or the technology, yeah. And I mean, compared with the therapeutic plasma exchange, you mentioned it, exchanging 8 to 12 liters of plasma is, of course, a big workload for the personnel. I think that's also something we always have to have in mind. Yeah. Yeah, and it's obviously working. It's doing what it should do. Yeah, or what do you think?
Well, I think that rarely, especially in extracorporeal liver support devices or technologies, it's so clear the causality between what you want to aim and how does this happen. I mean, sometimes the wonder is, and forgive me for the very colloquial approach, where the magic occurs. When you are applying albumin dialysis, you know that there is a washout. When you're doing therapeutic plasma exchange, you know that a replenishing of factors are occurring, and of course a washing effect is occurring. But when you have the chance to bind this with concrete removal that is documentable, then you have a bit of the insider view on how the things are occurring. And I think that this and how this can pose a clinical benefit from the patient seems, in my opinion, but again, open for debate, a compelling argument on why using hemoabsorption in this type of patients.
Yeah, there is one question here from a guest, from Anna Wojcik. How is the platelet count affected by the therapy? I think this is something Dana Tomescu also mentioned in her presentation at the ESICM. As far as I know, she said, yes, there is platelet reduction, but it's not clear if this is really due to CytoSorb and maybe also due to the CRT. We know that from other extracorporeal therapies that they remove platelets. And clinically, it was not at the end negative. So that was her comment. Is this also your explanation or your answer to that?
Well, the first answer is how low were the platelets before beginning the therapy? The patient with liver dysfunction, especially the ones that have acute and chronic liver dysfunction, but not exclusively, tend to be patients with thrombocytopenia, maybe because of a hypersplenism condition. So one has to start by minding starting values, and hemoabsorption, like other technologies, definitely might have, and I want to emphasize in the might, have an impact on platelets and how much the drop affects us with 150,000 platelets on our platelet count versus a patient that has 20 is a matter of debate. Remains a topic of caution. If I recall this correctly, there is a recommendation of caution, not a warning or a contraindication, but caution for that hemoabsorption with CytoSorb when a patient is thrombocytopenic. But needless to say, we have this caution with any invasive treatment where the patient is thrombocytopenic. And I would start by saying, if I cannot put the catheter to perform the hemoabsorption because of thrombocytopenia, then it's clear that I have to tackle that first before starting the therapy. And on top of that, as Dr. Tomescu clearly established, if I am treating patients with CRRT plus hemoabsorption, I don't know in which of the two aspects to place the responsibility where the drop of the platelets occur. With CytoSorb itself in a standalone mode, in patients that have preserved platelet function, this is not a problem. It has been used also in patients that have thrombocytopenia without clinical impact. A drop on platelet values might be neglectable if the patient does not have a bleeding event. And I think that if I had to choose, what would be my red flag to pay attention towards, is the therapy dangerous for the coagulation profile of the patient? I would take a look of reports of bleeding events, or I would take a look of clinically relevant need for transfusions. And numerically, there is growing experience in the use in liver dysfunction. This has not been documented yet. And this was also what Dr. Tomescu was documenting. An impact in lab values did not present the clinical repercussion that one could fear.
Yeah, when observing the other publications, we also could not see that there was a big problem with a big reduction of platelets in these patients. Yeah, is that correct?
Yeah.
Yeah. Okay, but what is so to say the threshold? When is the minimum, or you would recommend not to use CytoSorb? What would you say? I mean, there's, I think, as far as I know, one recommendation in our instruction for use, and I think it was 10,000. Is it correct?
Maybe a bit higher than 10,000, but I can go back to the beginning. If the hemoabsorption is done on elective basis, assuming that the patient is not in a life-threatening condition, then of course, my approach towards safety of the patient and obtaining or aiming a platelet count that is normal prior to start is clear. When the condition is life-threatening and when I cannot afford hours or days to make the decision, one has to consider and outweigh, and this belongs to the individual responsibility of us as physicians, to say, when is the right moment to start? If the patient under 10,000 cannot receive an hemoabsorption, it starts most likely and cannot receive an extracorporeal treatment because of the bleeding risk. Maybe, of course, we could also aim transfusion prior to starting the therapy and proceed with extra caution might be given, but I don't want to give any strict rule of thumb. It really depends on what is the criteria to start and the risk-benefit profile. So there is not, unfortunately, no definitive answer yet, not even from experts, because we always have to adapt this to the situation of the patient.
Okay, but in general, one could maybe say, in case you would still start CRT, you could also start CytoSorb. Yeah?
That would be a general
that could be something one we could agree here. Yeah.
Exactly.
Yeah. Okay. Yeah, very good. I'm just checking here the questions. Very nice presentation, Maria, said Gordana Taleska-Stupica from Slovenia. So as one can see, we are coming more or less to the end of our webinar. But in short, Maria, maybe you can give us some ideas. When would you start CytoSorb? What are the criteria to start here? You were mentioning bilirubin, for example, above 10. Of course, there has to be a trend. Yeah, it's not just a single moment when such a parameter is high, but maybe you can add some more to this question.
With pleasure. Like I said, I think that the first question is find your target. If you're treating because a patient has hyperbilirubinemia that is dangerous, then your criteria of starting would be in the safe side in bilirubin levels above 10 milligrams per deciliter, and this should lead your decalation of the therapy. And if your criteria to start is hepatic encephalopathy, then the ammonia value is really not the biggest outcome. It's not the biggest starting criteria. It's degrading. A patient that is in grade 4 hepatic encephalopathy is an emergency. And if this is unresponsive to therapy, this is a criteria to start. And as mentioned before, if there are other evidences of organ failure, and one that is very colorful, hemodynamic instability in the context of infection or not, that might add up to the critical condition of the patient with liver dysfunction, independent of the cause. It's also a patient that benefits from a start. And I think that these criteria, what is an emergency or what is your removal target, might be transferable to acute liver dysfunction, to chronic kidney liver dysfunction that presents an exacerbation, or to post-surgical sets. And last but not least, the patients, like I said, intractable pruritus tends to be a situation where this is not an emergency by our standard definition, though the patient will say otherwise, because for them is an emergency. But in this case, again, if your target of removal is bile acids, then your criteria to start is, why would I go invasive? Because every other option failed.
Yeah, thank you, Maria. I think we could talk about that, hours and hours. There are so many aspects. Every single indication is a topic in itself, and I hope in the near future we can talk, for example, about the use of CytoSorb after large liver resection, or, for example, the use of CytoSorb in liver transplantation. Before, during, and after, we heard already that even during liver transplantation it was already used in some centers. That's an interesting option. So there are many really nice aspects related to this technology and therapy. And I think there's enough content for many more webinars in the future. Yeah.
Oh,
So
I
I
believe
would, and for that, for this moment, I think we have to say now we goodbye. Yeah, at that stage here, I really think you was really great, and one could see the big potential of CytoSorb in liver dysfunction. Of course, we need more data, but obviously it's working. Yeah. And many clinics or many users like the technology, the therapy already. And there's a lot of experience-based knowledge already, and more evidence-based knowledge will arrive. I'm sure about that. There are several studies ongoing. And I like to thank all the participants here. And I also like to thank our translator, Peggy. I followed your translation here today a little bit. It was really excellent. Thank you, Peggy. And a big thanks also to Attila, who made this all possible from the technical point of view. So with that, I like to finish here. Wish you a wonderful evening and a wonderful weekend, and hope to see you soon, either live at a congress or together with Maria and other colleagues, and here on such a webinar. So, and with that, goodbye and see you soon.
See you soon. Enjoy the weekend.